Good evening, everyone. I, Dr. Ashita Punjabi Haku, on behalf of IFS MP chapter and IFS SIG on genital tuberculosis, welcome you all to this first session of the series Genital Tuberculosis. Our main, can you please mute all? Mr. Himanshu, can you please mute all? I can't. What I do.
Done, mom.
Okay. At the end of this series, we expect that everyone should have comprehensive insights and practical guidance to the management of this challenging disease. Dr. Ashita Punjabi Haku, I am MD of Gynae FNB Reproductive Medicine, and I will be speaking on topic enigma of genital TB today. So without much ado, let us start the session. In the words of Dr. Paul Farmer, tuberculosis remains one of the most difficult diseases to diagnose and treat, often presenting in forms that evade the traditional diagnostic methods. Dr. Paul Farmer, he was a physician and anthropologist who has done remarkable job in global health, especially tuberculosis in low resource setting countries. Talking about the pathophysiology of genital tuberculosis, it is always secondary to a primary infection in other organs, primarily the lungs. It can also spread hematogenously, and lymphatic spread has also been documented. Rarely it can have direct spread from the viscera. When we talk about genital tuberculosis, the tubes, they are involved in 95 to 100% of the cases. Endometrium, it is involved in 50 to 60% of the cases. Ovaries in 20 to 30% of the cases. Cervix in 5 to 10% of the cases. And in cases with endometrial involvement, tubes are involved in 100% of the cases. How genital TB can present? It can be asymptomatic in 10 to 12% of the cases, making it even more difficult to diagnose. There can be vague symptoms like fever, night sweat, anorexia, weight loss. There can be infertility due to tubal factor. There can be tubal blockage. There can be hydrosalpinx, tubo-ovarian masses, distortion of the tubo-ovarian anatomy. There can be endometrial damage, thin endometrium. Even in latent TB, there can be decrease impaired receptivity, and it can also lead to recurrent pregnancy losses. It can cause dyspareunia, menstrual dysfunction, because in 20 to 30% of patients, it can also involve ovaries. So there can be decreased ovarian reserve also. In cases in early stages, there can be heavy menstrual bleeding. There can be scanty menses due to damage to the endometrium. There can be prolonged menses. There can be amenorrhea. It can also lead to chronic pelvic inflammatory disease and chronic pelvic pain. Many patients who are not responding to the conventional PID treatment, many a times they have underlying genital TB. Natural history of the disease, uh, it can start as latent genital TB. Then there comes an inflammatory phase, and then later on, it can lead to endarteritis, fibrosis, and lesions. Now, why tuberculosis is still an enigma? Because there is little or non-specific symptoms. It's a possibacillary disease, and many of the tests which we have today, they have very low sensitivity. Then it's primarily a tubal infection. It involves endosalpinx, which is not amenable to sampling, and endometrium, it is shed off every month. Now, how to proceed with managing a case of genital tuberculosis where we have the suspicion. So very important is the meticulous history. You have to ask about any past history of tuberculosis, any family history of tuberculosis, women who are belonging to area where there is high TB prevalence, patients having long duration of infertility, unexplained infertility, history of other chronic diseases or condition which can cause poor immunity, like patients with HIV on immunosuppressive treatment, diabetes, history of pelvic inflammatory disease or vaginal discharge which is not responding to conventional treatment. On physical examination, there are no signs many a times. On local examination, if there is tubo-ovarian mass, one can feel the fullness of the fornix. There can be tenderness. Uterus can be enlarged sometimes due to pyometra. There can be abnormal vaginal discharge. Now, aim. Our aim before proceeding to the investigation is that we have to recognize that there is no single gold standard test for female genital tuberculosis. We need to avoid the overdiagnosis and unnecessary treatment. We have to diagnose the disease early before the sequelae set in and there is irreparable damage to the female genital tract. And we will also know about what's the role of hystero and laparoscopy in timely diagnosis. Am I audible? Hello?
Yes, mom. Yes, mom.
Yeah, okay. Regarding the investigation, so non-specific investigations include CBC with ESR. There can be lymphocytosis, increase in the leukocyte count. Then chest X-ray many a times can show old healed tuberculotic lesions, or in cases where there is active pulmonary TB that can be seen on chest X-ray. Regarding Montauk's test and interferon gamma release assay, their sensitivity is 55% and specificity is 80% in many of the papers. So they are not recommended alone. IGRA test, it has been FDA approved for diagnosing the latent genital tuberculosis. In USG, we can see the tubo-ovarian masses. There can be thin endometrium with calcification, intrauterine synechia, and hydrocephalus. HSG, on HSG, we can see the bilateral tubal block can be there, or there can be distal block. There can be presence of hydrosalpinx in the later fibrotic stages. There can be damage to the endometrium leading to intrauterine adhesion, many a times T-shaped cavity or obliteration of the whole cavity many a times. But all these changes, they will be picked up on HCG, mostly in the later stages when the damage has already been done. Microbiological test, these will be taken up in detail by Dr. Reena, just giving you an overview. So we need to get the endometrial biopsy or endometrial aspirate. The best time will be on day 21 to day 24 of the cycle. And that should be subjected to the following microbiological tests like histopathology, where we can see epithelioid granulomas with Langerhans giant cells and lymphocytes. Mostly they are near the ostia, and these granulomas, they take 3 weeks to form. Next is directly visualizing the bacteria. We can subject our sample to smear. For smear, greater than 10,000 bacilli per ml should be there. And for culture, it should be greater than 100 bacilli per ml. The conventional culture method, the LJ media, it takes around 6 weeks to grow the mycobacterium, and many a time this can lead to delay in the treatment if we will solely rely on this. Nowadays, there are new liquid-based culture media which can give the result and the sensitivity testing in 9 to 10 days. So the papers, they give the sensitivity of these liquid-based media at around 45 to 46%. TB PCR, it can detect, it is highly sensitive, it can detect 1 to 10 bacilli per ml, but it suffers from high false positive rates. TB PCR, yes, it can be done if you are having very high suspicion of tuberculosis in a patient, and this can be used to guide the laparoscopy in those patients. Then we have CBNAT or gene expert. MTB detection and rifampicin resistant can be detected in 2 hours, but this test again has very low sensitivity when we talk about the endometrial tissue. It is around 30 to 50%. in paper by Dr. J.B. Sharma et al., while it is highly specific. Newer assays have been defined in various papers. One is LAMP assay, loop mediated isothermal amplification assay. In paper by Sethi et al., they have observed high sensitivity of 66% by this test. It gives faster result and it's like less expensive than Gene Expert. So this was a paper by Thangappa et al. In 2011, where they have evaluated PCR culture and histopath in the diagnosis of female genital TB. Again, they have shown that the methods like AFB culture, HPE, and the culture AFB microscopy, they suffer from very low sensitivity. In their study, the sensitivity of HPE was 10.7%, while of culture it was 7.14%. So we need to realize that it's a possibacillary disease. We have to have the TB mindedness. We cannot only rely on investigations. We have to take the meticulous history. We have to do our physical examination, and then we should do all the relevant investigation. And we should always proceed with the TB mindedness. Now we have a very high suspicion of TB in a patient, and all our tests, they are coming out negative. And now we will discuss what will be the role of hysterolaparoscopy in such patient in the diagnosis of genital tuberculosis. On hysteroscopy, you can have chronic endometritis, early sign, as we have discussed. Again, it involves endometrium in only 50 to 60% of the cases. So in cases which will be involved, the early changes will be, there will be focal hyperemia. There can be diffuse hyperemia. We can see micropolyps. Micropolyps are growths which are characterized by accumulation of inflammatory cells. They are less than 1 mm. They have a vascular stalk and they can float in endometrium. Presence of this micropolyp, they represent that there is endometrial reaction to some inflammation. In this paper by Cicinelli et al., they have shown that the presence of endometrial micropolyps at fluid hysteroscopy, it is very significantly associated with endometrial inflammation, and it can be considered as a diagnostic sign for chronic endometritis. In hysteroscopy, we can see periosteal adhesions. We can see pale endometrium. There can be endometrial tubercles. We can see caseation in some cases. Now, in later stages, when the fibrotic changes have already set in, then we can see that there is poor distensibility of the uterus during our hysteroscopy. There can be lateral wall and fundal adhesions. There can be T and Y-shaped uterus. There can be intrauterine adhesion, and there can be completely obliterated cavity in severe cases. Regarding the laparoscopy, in early inflammatory phase, we can see inflamed rigid tubes. There can be thick cornua. There can be caseation. There can be tubercles. There can be agglutinated fimbriae and intravasation of the dye. In later stages, we can see cornual block. There can be block at junction of isthmus and ampulla. There can be hydrosalpinx, the tubo-ovarian mass, and perihepatic adhesions. Now, these are a few photographs. This image, it is showing thickened cornua. This is showing abdominopelvic TB, where we can see that whole of the omentum and gut, they are all forming a mass. They are adherent to the uterus. So this is the perihepatic adhesions. This is bilateral tubo-ovarian masses. So again and again, I'm saying that this disease is an enigma. We need to have the TB mindedness. I'm going to show a video where a patient, she was referred to me for IVF for bilateral tubal blockage. She had been married for 6 years. I had done IVF for her sister, and she was having a block tube again, and she had history of TB thumb, and she had taken ATT for 1 year during her childhood. And when this patient came to me, all her tests, they were negative. The basic endometrial aspirate, they were negative. And with high suspicion, I posted her for diagnostic hysterolaparoscopy. So this is what I saw. So whole of the abdomen, this uterus, everything, it is inflamed. whole of the omentum, it was covering the abdominal wall. Very sparsely, I could get the space to make my ports. You can see even the rectosigmoid, it is completely adherent to the anterior abdominal wall. I couldn't see the liver. And this finding, this caseous material, this has been described by Dr. J.B. Sharma in his recent article as white cotton ball sign. This is the image that was given in the article. And this is the presence of caseous material, which is which looks like a cotton ball. That's why they have given this the name. And now, on the basis of laparoscopy, I have started the patient on ATT, as she has never received it before in consultation with the chest physician. And I'm also awaiting her culture report. Again, other things which we can see in laparoscopy are these caseating tubercles and rigid tube. Again, in papers by Dr. J.B. Sharma, they have given few signs in laparoscopy. This is hanging gallbladder sign. Due to perihepatic adhesion, the liver, it is completely adherent to the anterior abdominal wall, and this gallbladder, it can be seen as if it is hanging from the liver. Then the laparoscopy finding of Sharma's ascending colon adhesion sign, again in case of abdominopelvic tuberculosis, and this is a kissing fallopian tube sign. This is a very good article by my colleague. This articles come from Bansal Hospital, Bhopal, in which he has described the laparoscopic and hysteroscopic finding in cases of TB. So they have taken more than 16,000 patients who had undergone the laparoscopy over a span of, I guess, 9 to 10 years. And in those 1083, they had the hysteroscopy laparoscopic finding, which was suggestive of tuberculosis, and only 309 were diagnosed with genital tuberculosis on diagnostic test. And then they have correlated these findings in those who were negative. Logistic regression, it was implied, and they have found signs which are highly diagnostic of genital tuberculosis. Even though the tests are negative, we have to realize that it's a possibacillary disease. The signs which were highly diagnostic, they were abdominopelvic adhesions of various grades, isthmoampullary block, tubercles, tubo-ovarian mass, hydrosalpinx, complete tubal destruction, tubal diverticula, and rigid tube. So according to Index TB Guidelines 2016, again, realizing the importance of genital TB being an enigma, being a possibacillary disease, they have made these recommendations that we can make the decision, diagnosis of genital TB and start ATT based on any one of the following. That is laparoscopic appearance, which is typical of genital TB, any gynecological specimen which is positive for AFB on microscopy or positive for MTB on culture, or any gynecological specimen with finding which is consistent with genital TB on histopathological examination. So this illustration is a very good example of subjective perspective. Person who is holding the trunk of elephant, he thinks that this is something large tubular structure. The person who is holding the tail thinks it of some wiry thin structure. Until unless they all will collaborate their perspectives, only then they can arrive at a real picture. Same is the case with the genital TB. There is no single gold standard test. We need to combine various tests along with our history and physical examination. Sharma et al., they have given composite reference test, that is, in the absence of availability of any single sensitive and specific test for detection of genital TB, we need to have combination of tests. It increases the sensitivity and detection rate of genital TB, and it avoids false positive rates. So the patient with history of infertility, menstrual dysfunction, chronic pelvic pain, abnormal vaginal discharge, having family history of TB, past history of TB or ATT, you have to carefully examine the whole body, pelvic examination for any evidence of TB or adnexal mass. You can schedule the patient for endometrial sampling or biopsy on day 21 to 24, but you have to tell them they don't have to have contact in that cycle, so that you may harm any pregnancy if there is. Then that sample has to be sent for AFP microscopy, culture, gene expert, HPE. Uh, for AFB microscopy, if it is positive, you can start the TB. It will be a definitive genital TB. Or if culture, gene expert, HP, they are positive, you can start the TB, making the diagnosis of definitive genital TB. But if all these tests are negative, you can do PCR. If there is positive PCR or you have high suspicion of genital TB from history, from symptom, from examination, you can subject patient to diagnostic laparoscopy. If you find definitive finding of tuberculosis, which according to their paper is caseous nodules, BD tube, tubercles, you can start ATT based on laparoscopic finding. If there are probable findings of genital TB, that is straw color fluid, abdominopelvic adhesions, hydrosalpinx, pyosalpinx, convoluted and hyperemic tube, you can make probable diagnosis of TB and start the ATT. If there are normal findings, so you don't have to start the ATT. Also, if there is positive PCR, you have high suspicion, radiological test shows some adnexal mass, again, you can make a diagnosis of probable genital TB and start the ATT. Uh, I just want to discuss about this MUM1 IHC. This is also a test which we used to send when I was there in Bansal Hospital. We used to send this test, and I have done a study on this also. MUM1, it's a lymphocyte specific transcriptional factor. It's a member of interferon regulatory family. Um, Predominantly the B lymphocytes, they reside in the basalis layer. Until unless there is endometritis, only then they can be detected in the functionalis layer. Mostly in the functionalis layer, there is abundance of T lymphocytes. So if on our endometrial sample, there is presence of MUM1 positive B cell, that is plasma cell, then it is diagnostic of chronic endometritis. According to this paper by Parks et al., it was in 2018, it is a more sensitive marker of endometritis than CD138 immunostaining, and also it gives a clean background as compared to CD138 immunostaining. So at Bansal Hospital, along with our DHL, we used to send the sample for histopathology, AFP microscopy for culture, gene expert, and MUM1 IHC. So this was a study. Out of 391 patients who underwent hysterolaparoscopy over a span of 1 year, 60 cases, they were detected as genital TB on the basis of laparoscopic finding. All these tests were sent, and what we found out that sensitivity and specificity of this test was 46.6%, and it was highly specific, 85.8%. So even though it was a retrospective study, the sample size was not large, but it was the first study to evaluate MUM1 IHC to detect chronic endometritis due to genital TB. So in cases where gene expert or histopathology are negative, this test can be used to rule out the genital TB. Treatment part, again, in the coming sessions, it will be taken up in great detail. In brief, now there is no category system is used. Now either it is first line sensitive drugs or they are resistant drugs. So those who are sensitive, they are given HRZs, that is isoniazid, rifampicin, pyrazinamide, ethambutol for 2 months, and for next 4 months they are put on isoniazid, rifampicin, and ethambutol. And in India, TB notification policy, it mandates that all the patients with tuberculosis, including genital TB, they are notified through NICSHE, which is the TB notification portal. So this was a book published in 1952, The White Plague, Tuberculosis, Man and Society. It aptly said that TB present problems that transcend the conventional medical approach, that TB has its own social and economic bearing. And even after so many years, in 2024, this disease is still an enigma for a great mimicker, and it's still a challenge for us. And when we especially talk about the reproductive medicine, it can have the devastating effect on a female's genital tract. So take home points are that it's a possibacillary disease. It can be missed on our conventional test. We need to have high TB mindedness. We need to have meticulous history, physical examination, the combination of tests they are required in diagnosing it. Meanwhile, we have to stop overdiagnosis tuberculosis, and there is a great role of hysteroscopic and laparoscopy in the diagnosis of tuberculosis. Thank you. Mr. Himanshu?
Yes, ma'am.
You can share the slide of Dr. Reena. Any questions of both the session can be taken up in the end.
Very nice talk, Dr. Ashita.
Thank you,
And
ma'am.
we are really looking forward to hearing Dr. Reena's talk. So you can start with by introducing her.
Yes, ma'am. It gives me immense pleasure to welcome Dr. Reena Ravindran, ma'am. She's senior consultant at Institute of Clinical Microbiology and Immunology, Sri Gangaram Hospital. She has the total experience of 21 years, and her areas of interest include mycobacteriology, antimicrobial resistance, infection control, and quality control. She had been looking after tuberculosis diagnosis for more than 16 years. She is an active member of academic and research activity, and she has many publications to her name in national and international journals. We welcome you, ma'am.
Thank you, Dr. Ashita, for your kind introduction. Hope I am audible.
Yes, ma'am.
Okay. Is my screen visible?
No, ma'am, not yet.
Not,
Is it visible right now?
Yes, ma'am, visible.
Okay, okay. So good afternoon, good evening rather, everyone. So with the background given by Dr. Ashita, I think my job is easier now. So we can proceed to laboratory diagnosis. So in a country like India, this topic is becoming more and more important because, as we all know, our country is the highest tuberculosis burden country in the world, contributing to 24% of the world tuberculosis cases, and it is also accounting for about 1/4 of world's MDR tuberculosis cases. And also one alarming factor is that among MDR tuberculosis TB, 21.8% of them were found to be even fluoroquinolone resistant in a recent study. So even though the major brunt of this is contributed by pulmonary tuberculosis, extrapulmonary tuberculosis, including female genital tuberculosis, is an important cause of morbidity and infertility in countries with high prevalence. So the problem is in estimating the incidence. It is challenging because, as Dr. Ashita has already explained, many of them are asymptomatic or ambiguous symptomatology, lack of effective diagnostic methodology, everything is there. So the only available information regarding the incidence of female genital tuberculosis is from the infertility clinics. So a review article was showing in India, it varies from 3 to 26% in different studies. Another study was quoting a figure of 16.1%. And a study from North India was quoting a figure of as high as 48.5% of the ladies attending the infertility clinics were diagnosed to have tuberculosis. Whereas in a country, developed nation like United States, where the tuberculosis is not endemic, this figure is as low as less than 1%. So the diagnostic dilemma is because of the asymptomatic presentation, chronic nature of the infection, and as Dr. Asita was again repeating this point, post-bacillary nature. So because of the low bacillary load, many a times the diagnostic tests are likely to become negative, and also difficulty in obtaining appropriate samples because invasive procedure is required for obtaining an appropriate samples. So the available laboratory tests can be enumerated under microscopy, culture, and we have a wide array of molecular diagnostic tests, then the antigen detection, then the test for latent tuberculosis, and histopathology is also there. So this opportunity I am using to introduce the new definition of drug-resistant tuberculosis also. Because MDR-TB is already known to everyone, that is resistant to INH and rifampicin. If there is an additional fluoroquinolone resistance, it is termed as pre-XDR-TB. And in addition to fluoroquinolones, if there is resistant to any one of the group A drug, that is bedaquiline or linezolid, then it is termed as XDR tuberculosis. So one fact which I want to reinforce here is regarding sample collection. The principle is GIGO, that is garbage in, garbage out. Diagnostic results depend on the quality of the specimens. Poorly collected or non-representative specimens may give us a false negative report, or they fail to isolate the causative microorganisms. So the recommended samples here include fallopian tubes. I mean, Dr. Ashita had already explained the percentage of involvement. So the samples which we expect, or in our experience, which has yielded good results in culture is these are the samples like fallopian tubes, endometrium, ovaries, peritoneal or omental biopsies, lymph node samples, cervix, and sometimes even urine is also giving a positive result. And also, when you are doing an invasive procedure, whether it is a laparoscopy or a hysteroscopy, choose the affected areas wisely. Like when you do the procedure, you should look for areas of calcification, granulomas, tubercles. So if you are picking up samples from such affected areas, like in this picture, you can see caseous nodules, and Dr. Ashida had shown us a lot of pictures, like here you can see tubercles. So if you are selecting an area which is affected and send that part for the test, like a biopsy is taken from such affected areas, the chance of getting a positive report is much higher. And endometrial biopsy is another sample, which is actually the commonest sample which is received in the department for culture as well as for molecular assays. But endometrial biopsy, I would like to tell you that this is not the best sample because endometrium is shed on a periodic basis. And it has to be collected between the 20th and 25th day of menstruation. And menstrual blood, in contradiction to the belief by some people, is not a recommended sample for any of the microbiology investigations. See each one of the microbiology investigations one by one. Smear microscopy, the sensitivity is very poor for extrapulmonary tuberculosis and especially for the genitourinary tuberculosis, because even the improved microscopy techniques like direct fluorescent staining will pick up bacteria only if the load is 10⁻³ to 4 organisms per ml, which is very less often observed in genital tuberculosis. Then we have the TB culture. TB culture, we have the more sensitive methods like liquid culture, automated liquid culture systems. They are much more sensitive and faster than the older LJ method. When the sensitivity has improved, when the LJ was used as the culture, it was as low as 7%, and now it is coming to near about 50% sensitivity is there for culture methods for tuberculosis. This is from literature I am saying. So here again, we should consider the facts like the appropriate sample or not. That factor is also to be considered, but specificity is 100%. And there are latest methods, the diagnostic methodologies which we have. Once the bacteria has grown in culture, there is immediate identification of the species of the mycobacteria, and drug sensitivity report also will be released to the clinician as soon as possible. Then this is an array of molecular diagnostic methods which are either WHO approved or FDA approved methodology. Here I would, this is a humble request to my clinical colleagues, is that whenever you are depending on a PCR report for the for diagnosing and treating tuberculosis, please go for a either WHO approved or CDC, not CDC, the FDA approved techniques for diagnosis of tuberculosis, because there are a lot of in-house PCRs which are giving false positive reports, and which we have observed in our experience also when the patients walk in with that kind of reports. So Gene Expert was already mentioned. Gene Expert Ultra is the one which is being used now, which is much more sensitive than the earlier Gene Expert, can detect as low as 16 colony forming units per ml. The overall sensitivity of Gene Expert is around 90% and around 80% for extrapulmonary tuberculosis. But for female genital tuberculosis, the sensitivity was observed to be about 35 to 50%. Again, because of the, probably because of the sample collection issues and postbacillary nature as well. And specificity is quite good. And when the new Gene Expert was introduced, that is the Ultra one, we started to have a problem, mainly clinicians, because there is a report category in this that is MTB detected trace. So many a times clinicians come back to us and ask, what does it mean, MTB detected trace? Should I treat the patient or not? Yes. WHO guideline is that trace codes should be considered as true positives and the patient should get ATT. Only in case of sputum samples, a second sample is warranted and the test can be repeated. And if the second test is also positive, the patient can be put on therapy. But in extrapulmonary samples, there is no need of any second test or anything. Patient can be straight away put on therapy. And in the Gene Expert, we have a later addition, that is Expert XDR category, which is looking for other drugs like INH, fluoroquinolone, and injectable drugs, and ethionamide also for drug resistance right from the sample. So once the earlier, that is the Ultra is positive, you can send the sample for XDR, and the good array of antibiotic profiling is available to you to start the therapy. Then there is another test called TrueNat, which is an Indian version. Probably I can call it as an Indian version of the Gene Expert. It is a made in India test. This is also a quite good test with a sensitivity, overall sensitivity of about 85% when we were quoting sensitivity of 90% for Gene Expert. And this is much cheaper than Gene Expert, and the specificity is quite good. And but I couldn't find any article which has investigated or tested this for female genital tuberculosis per se, but the test is showing good sensitivity and specificity in extrapulmonary samples, and we ourselves also have tested in gastrointestinal samples, etc., and showing good performance. Then the probe assays. The application of line probe assays in genital tuberculosis directly from the specimen is not there. So application directly from the specimen is for pulmonary samples. For genital tuberculosis specimens, this can be utilized to detect drug resistance once the culture has come positive. First line probe assay is looking for INH and rifampicin sensitivity. And then second line probe assay can give us information regarding the sensitivity of fluoroquinolones and injectable drugs. Then for completion's sake, loop-mediated isothermal amplification, which was already mentioned. And then there are certain newer tests, like high-throughput equipments are there, one from Abbott, one from BD Max, etc. These are primarily recommended for pulmonary samples, but extrapulmonary samples can also be run in this. The sensitivity is less. But once these tests are giving you a positive report, you can believe that report because the specificity is quite high and you can put your patient on therapy. Now the talk of the town is on gene sequencing. So next generation sequencing is the technology which is being used now. It combines the diagnosis of bacteria along with drug resistance mutations for all 16 anti-tuberculous drugs simultaneously, along with molecular epidemiology from a single test sample. And as of now, the test is approved and marketed for testing directly from sputum sample. Extrapulmonary samples, some manufacturers have launched their equipments and extrapulmonary samples are also being catered. But in extrapulmonary samples, now the sensitivity is very low. So maybe in near future, we can expect such more improvement in this sequencing, tailoring for extrapulmonary samples as well. So the current status of sequencing is that it is currently, since it is a complex process, it is available only in reference laboratories as of now. And we need people with bioinformatics skills for analyzing the data, and high cost is there. We are in the process of starting this sequencing. So once we start, probably I'll be able to gain more information how we can modify or the test for extrapulmonary samples as well. So here I would like to give you 2-3 cases which we have come across in our hospital. These are little older cases, but I think they're still holding some value. This is a 34-year-old female who was married for 1.5 years. Patient came with complaints of infertility, and there were findings on laparoscopy, omental adhesions, etc. were present. And the sample we received in our laboratory was an endometrial biopsy sample, which was negative for a direct fluorescence staining for AFBs, but culture was positive, and immediately molecular assay was done for the sensitivity, and the report was released to the clinician as early as possible. This is another patient who came to 30-year-old lady who came to our hospital with primary infertility. When the patient came to our hospital, the patient was already on second line ATT. So this patient was under treatment in some other facility where they had put the patient on a first line ATT on the basis of an endometrium PCR positive from some local PCR, which we didn't have. It was just written endometrium PCR positive. So what was this PCR done? We don't know. So this patient was treated for 9 months, and subsequently the PCR was again positive and the patient was put on second line treatment. That is the state at which the patient had come to Gangaram Hospital. So in Gangaram, laparoscopy was done, and there was no, and even hysteroscopy was also done, and there was no pathology revealed. So endometrial biopsy was taken and sent for culture, as well as the molecular test which we had at that time was gene probe. So all the tests were negative. So ATT was stopped and the patient conceived through artificial insemination. So I showed this case just to reinforce the fact that just don't go by or just don't believe any PCR. So whenever you are sending your patients for investigation, or if any patient is walking into your OPD with some PCR report, ensure that this PCR is an FDA approved, because we have so many FDA approved WHO endorsed tests. Then why do we go for in-house PCRs, which are giving a very varied specificity, which can vary between, studies are saying some are claiming 100%, but the specificity is very low in many of the studies. Actually not a genitourinary tuberculosis case, but still this could carry some information to the residents who might have joined. I thought here, this is a 54-year-old female who was presenting with pain, redness, and swelling in the infraumbilical region. So this patient gave a past history of total laparoscopic hysterectomy with bilateral salpingo-oophorectomy, which was done 1 month back from some other facility. Then the patient came to our hospital with the pain and redness. So it is very obvious this is port site infection. So re-exploration and debridement was done, and the tissue, debrided tissue, was sent to microbiology laboratory. So the tissue was negative for the routine culture, but the AFB stain was positive. But what we grew in culture was Mycobacterium abscessus. This is a non-tuberculous mycobacteria where the treatment is different from that of Mycobacterium tuberculosis. Here we have to give a regimen based on clarithromycin or azithromycin along with other antibiotics. A 3-drug course is usually given. So here this is a problem associated with laparoscopic procedures, whether it is diagnostic or whether it is for treatment. And here, if the laparoscopes are not sterilized, maybe high-level disinfection is the system which is being followed. So if it is not followed properly, people can get these kinds of infections as well. Then we have some biomarkers. One is an antigen, that is lipoarabinomannan, which is released from metabolically active mycobacteria. The advantage of this is that this is detectable in urine. But the problem associated with this is that very low sensitivity. In fact, in a normal population, only 13 to 51%. So WHO has recommended this test only for countries with or those individuals with HIV positivity or in a population where there is a high HIV prevalence, as in case of some African countries. In our population, the sensitivity of this test is very low. Then this is a test which is under development, but I thought I will introduce this test to you. Here, this is the mycobacteria is detected from the sputum, urine, or breath of the patient. Here, this is a point-of-care device already developed by some manufacturers. And here, this is like something which is used for detecting drunken driving by traffic police. Here, the patient is asked to blow into this device, and if tuberculosis bacteria is present, Mycobacterium tuberculosis is present, the equipment will give a positive signal within 10 minutes. But this is primarily for pulmonary tuberculosis, and the role in extrapulmonary tuberculosis is not known. And here again, this is not approved as of now. This is under evaluation. Then now we will move on to the test based on immune response of the patient, which is already mentioned. We have the Mando test, and then we have the interferon gamma release assays. And there is a new test which I will tell you. This is called CTB. This has the combination of specificity of interferon gamma release assay and the ease of performance of Mando test. Because this test, the antigen used is the same as that of IGRA, but it is given like Mando test. So here the cost is less because there is the laboratory facility needed or the tubes needed for IGRA is not there. But at the end of the day, whether it is Mando or IGRA or CTB, these tests, these immune-based tests cannot differentiate between active tuberculosis and latent tuberculosis. And because of that reason, these tests alone cannot be used for diagnosis of tuberculosis, and they can be used only in conjunction with other diagnostic tests for identifying a patient. And this is the last test I would like to tell you about is, this is again a new test which is under development. We can expect it shortly. This is based on the immune response of the host. That is, when the mycobacteria is multiplying in your body, certain host genes of the human being genes get upregulated. So this test is detecting that upregulated genes. So here again, the advantage is of sample collection. This is just a finger prick sample that is needed for this test. This is a cartridge-based test as the Gene Expert. It's the same equipment. This method is being trying to be standardized. This is again under evaluation. If these tests come up in the near future, maybe we can hope for a better diagnosis, at least in difficult cases like genital tuberculosis. So as Dr. Ashita had already mentioned, because of the challenges in diagnosis, it is a composite reference standard, which we may have to use in many a times, where we use a combination of all these technologies available to us. And treatment is also already discussed. If it is drug-sensitive TB, it is same as that of pulmonary tuberculosis treatment. If it is MDR tuberculosis, the regimen chosen will be depending on the sensitivity of the available drugs. It could be varying from the 6 months to 18 months regimen, or sometimes even longer. And here, one thing is, the difficult thing is periodic assessment of the patient, because we cannot get repeat samples easily, because sample collection itself is so difficult, then repeat sample is even more difficult. So periodic assessment would be based on clinical and radiological assessment, and people follow up using ultrasound. And I have even seen studies where people have done follow-up laparoscopy also, and have mentioned like reduction in tuberculosis, reduction in the beading of the tubules, etc., etc. Or maybe there is increase in the endometrial thickness. These are the expected findings when you follow up radiologically as well. And why I am talking about is resampling of microbiology investigation. When is it indicated? Because when in the follow-up, radiological follow-up is not showing evidence of healing, that is when a resampling for microbiology investigation is indicated to rule out amplification of drug resistance, whether you are giving the right therapy to the patient or the patient has developed additional resistance. So as you all know better than me, long-term sequelae are expected. Post-treatment conception rate is 12 to 23% as per literature. Ectopic pregnancy, spontaneous abortions, etc. are observed even after therapy. And if the endometrium is minimally scarred, but the tubes are affected, I think you will obviously try for IVF. So here, one thing I would like to tell you is that, and when you are planning for IVF, if there is even a slightest of suspicion of tuberculosis, then kindly do the best possible to look for to diagnose tuberculosis. Because if you proceed with the IVF without diagnosing, there are cases of congenital tuberculosis, or there is aggravation of the pelvic tuberculosis of the patient. So every attempt, I feel, should be done for the diagnosis and treatment of the patient. So I would like to conclude by saying that the right treatment at the right time is a dream for many, and we need to turn it into reality. Thank you. I would be happy to take up any questions if there are any questions.
It was a very enlightening session, ma'am. Thank you so much for so much of insight. Ma'am, ma'am, there is one question in chat box. Please throw some light on latent tuberculosis.
Okay. See, in a country like, I actually, since it is a very broad question, I don't know exactly what you want to know from me, but I'll tell you in summary. In a country like India, latent tuberculosis is a common thing, because, you know, each one of us would be exposed to tuberculosis sometime or other during our life. So latent tuberculosis is a very common thing. So when is the treatment indicated? That is the question. So like in developed nations, they treat even latent tuberculosis with INH and rifampicin, or sometimes only rifampicin. But in our country, we cannot treat, and it is not indicated also in high endemic countries. So here we look for latent tuberculosis only in certain conditions. So where do we look for latent tuberculosis? When we are planning some immunosuppressive therapy, or like patient in rheumatoid arthritis and all that, where they are planning biologicals, or when the patient is going for transplantation, transplantation, or in HIV patients, etc. In such situations, people are screened for latent tuberculosis, and if they are detected to be positive, they are treated. So if there is something more specific, whether the person want to know, please ask me. Like, I mean, I don't know exactly what you wanted to know from me.
What sample should we take for adolescent girl to rule out the genital TB? I think it should depend on what are the symptoms, but again, for unmarried girls, we can't take the endometrial aspirate or biopsy. If due to some reason, I think again, then we'll have to go for menstrual blood, but that should be on the same day. Any inputs from you, ma'am?
See, actually, menstrual blood is not a recommended sample from
Recommended, yeah.
microbiology point of view. Because if you are taking it up for any PCRs blood sample, the PCR will get inhibited. So that that the sample itself is not good for PCR. Second is that is something which is shed. Even even endometrium, we are saying it is being shed every month. So menstrual blood, even studies are also shown that menstrual blood is not a recommended sample. So I don't know how feasible it is. You only would be knowing. Do you consider laparoscopy in such cases?
Yeah. There was one case, 1 to 2 cases where the patient presented with amenorrhea.
Yeah.
And on this USG, we could get the thin endometrium. We had posted her for laparoscopy, and yes, we could found, and there that was possible because we can send the caseation, and it was positive for culture.
Yeah.
That we can do. So I think it will depend on how much suspicion we have.
Yeah. Because menstrual blood is actually an eye wash, I'll tell you, just to to give comfort to us that we are investigated.
Yeah.
Otherwise, it doesn't yield anything.
Okay. And regarding the tests like TB Gold and quantiferon test, do you think there is any relevance for these adolescent girls?
See, here again, I thought I had mentioned about that. So TB Gold is more specific than Mando test for detecting latent tuberculosis. Detecting latent tuberculosis, I'll tell you, because it doesn't differentiate between active and latent tuberculosis. But there is a new version of TB Gold, which is called TB Gold Plus, which is with 4 tubes. So in this tube, what the manufacturer claim is there is an additional tube called CD8 tube. So if the value of interferon gamma released from CD8 tube is higher than that of CD4 tube, then it gives us some indication that this is more likely to be active tuberculosis than latent tuberculosis. But you cannot, this is only likely, more likely to be active tuberculosis, but nobody is saying this is active tuberculosis. But there are other factors, like you have some radiology doubts, some strong history, everything together, and you are giving a good like IGRA report, quantiferon gold plus report, everything together, probably you can consider that patient. Otherwise, only IGRA positive, everything else negative.
Is normal.
Then we don't know. It could be latent TB.
Again, like we discussed in CRS, we have high suspicion for this, and we are having any radiological findings.
Exactly.
Then that can be taken as
yes, and
a ground
additional
to start the
evidence.
ATT.
Additional evidence. Yeah.
For the Gene Expert Ultra, how much does it cost?
Gene Expert Ultra in private setup, it would be costing around 4,000. But see, it is available because there is a lot of government sponsor, not what is a subsidized Gene Expert is available in many centers. So in case if some patient cannot afford that much, then I think you may have to find out which is the nearest facility which is doing Gene Expert for free, and you may send. Otherwise, if you send it into private hospitals, it may cost 4,000, around 4,000 rupees.
Okay. On suspected TB with thin endometrium with hysteroscopy, endometrial biopsy, what all tests need to be done? I think we have been taught, because I have done my F&B from an area which is very much endemic with tuberculosis. We never did hysteroscopy alone. If we have high suspicion patient is having thin endometrium, we always do hysteroscopy and laparoscopy, in which we can find the laparoscopic findings, and also we can have the specimen to be sent for microbiological detection, because already the endometrium is thin. In fibrotic stage, we might not get anything in the results with endometrial biopsy. This is my take.
For microbiological tests, if you are asking for, you should definitely send for culture as well as gene
Yeah.
expert if it is available.
Yeah.
If gene expert is not available, look for the other molecular tests like TrueNat or anything which is available, but an FDA approved one and a culture. Microscopy you can definitely send, but the yield is very less in microscopy. Very rarely we get positive.
What should be the test of choice for genital TB and abdominal TB? I think there is no single gold standard test for detection of tuberculosis. Again, CRS has to be followed.
But every attempt, I would tell you, whenever possible, before starting therapy, every attempt should be made for a laboratory diagnosis, especially a microbiology test, because in case the culture, even though we are saying it is only 50% sensitive, if it is coming positive, then you are 100% sure about your diagnosis, and also subsequent to culture, you can do drug susceptibility test.
Sensitivity, yeah.
Help the patient treatment.
Can ATT be repeated if patient has taken 15 years back and endometrium is showing persistent fluid with eaten up cervix? So again, I think I have seen cases where we have to give the ATT again, but again, as ma'am has said, we have to send the specimen for the diagnostic testing as much as we can do. And also we need to know the sensitivity this time to guide our treatment. What test is indicated to diagnose latent TB?
We already discussed there are 3 tests. Mando is not very Mando is not very specific, because Mando test comes positive even if you are exposed to environmental mycobacteria. Because in our country, there is a lot of environmental mycobacteria also. And also the BCG vaccination, because we give vaccination to all babies at birth. So even that can also give Mando positivity. So Mando is, even though it is sensitive, we say it is not specific. So in that point of view, interferon gamma release assays, which are using Mycobacterium tuberculosis specific antigens. So that way it is slightly more specific than that of Mando test. And CTB is a new test which can be replaced for IGRA. But ultimately, IGRA is superior to Mando without any doubt. But how much utility it has is in conjunction with other diagnostic tests, not as a standalone test.
What is the role of blood tests like TB Gold? It has already been taken. IGRA and Montux along with imaging test. I think we have discussed this also.
Yes.
Role of tuberculin test in diagnosis.
Tuberculin test is Mando test. So Mando test, actually, again, you see in facilities where you don't have a provision for IGRA, yes, Mando test can be used. But again, it doesn't, standalone test, it doesn't have any role. Even with other, like if you have some laparoscopic findings, which could be tuberculosis, you are in doubt, because Dr. Ishita had explained some of the findings are for sure short for tuberculosis. Some of the findings are you are a little a doubt. So in such cases, if you have a strong positive Mando also, maybe together you can use it for the diagnosis. That's what I feel.
If menstrual blood show PCR report positive treatment, again, ma'am has already discussed, we should not send, we should not send menstrual blood, plus PCR it suffers from high false positivity rate.
Yes. you should know what PCR, whether it's an approved PCR, because all the molecular tests come under the category, most of them come under the category PCR. But what is the name of that PCR? If it is a nameless PCR, be little wary about it. They are in-house PCRs.
Empirical ATT, is it valid legally for thin endometrium or persistent endometrial fluid? Again, in CRS chart, we have diagnosed either it has to be definitive or you have to subject the patient to hysterolaparoscopy to see if there are any findings consistent with ATT, or if there is any test, radiological test or microbiological test to support your diagnosis. Ma'am, your take on this empirical ATT, because many a time we can't get anything and we have very high suspicion.
Empiric ATT is not easy to take.
Take.
Easy on the patient also, and also we are adding to the drug resistance in the population also. So empirical ATT, I'm not sure, because when we can use a composite reference standard, which is comprising of so many things together,
Thanks, yeah.
I think at least 2 or 3 tests together, maybe you may be able to justify your ATT.
Yes, chance.
Just because you are not finding anything, giving ATT, I'm not very sure.
Yes.
whether-
If on USG it shows enlarged lymph nodes and patient has signs symptoms, should be do in biopsy or go by blood test? Again, you should follow the CRS
Should
and whether genital TB.
wherever possible, take a biopsy. Like if you can, if the lymph node is accessible, definitely take. Even if it is inaccessible, whether it is ultrasound guided FNAC, you can take sometimes. Whether you can laparoscopically guided biopsy, you can take. Any possible way, if you can take a sample, that will be the best. The blood test is, I don't think any blood test can, because mycobacteria is present in blood only for a very short while. When you go through the pathogenesis of mycobacteria, the bacteremia is a very short time. After that, it will go and lodge in certain areas which is of its preference. So you won't get it in blood. You will have to find those areas where it has gone and lodged.
There's so many questions. In cases of endometriosis, can we suspect TB on the basis of non-specific lesions? That is, can they coexist? They can coexist, but again, you can have, on the basis of history, physical examination, you can have the suspicion, but again, you have to have some definitive finding to base your suspicion. And again, tuberculosis is a great mimicker. There is a paper where the lesion, it was thought to be because of endometriosis, and when the laparoscopy was done, um, the findings were of tuberculosis, and final pathology report also came as tuberculosis. So it's a great mimicker. You can have TB mindedness, but you have to have some definitive findings so that you may not miss on both the diagnosis. Either it is endometriosis or tuberculosis. Hysteroscopy, laparoscopy show pale, thin endometrium with amorphous debris near ostia. Lab showed tobacco pouch appearance with bilateral block, pre-tubes. Histopathology negative, culture negative. Can you start the ATT? So, as we said that we need there in the papers, there are definitive findings and there are probable findings. Whatever you are saying, they fall in probable findings. If you have high suspicion on this, you can start ATT based on probable diagnosis. Presence of caseation, tubercles, adhesions which are vascular, very thick plastic, they are definitive diagnosis. Yes, ma'am. I think we have taken all the questions.
Yeah.
Thank you so very much, ma'am.
Thank you.
You have answered all the cases. Thank you so
Thank
very
you
much,
for
ma'am.
having me.
Yes, ma'am. Priya, ma'am, are you there?
Hello.
Hello. Okay, so with this, I would like to thanks IFS MP chapters, Dr. Priya Bhave ma'am, Dr. Sonu Balahara ma'am, and Dr. Nitin Lat sir. Uh, we will be having these sessions twice in a month, and the end of the session, um, we should be able to diagnose and treat the diabetes, sorry, treat the tuberculosis with utmost confidence. Thank you so very much, everyone. Thank you so very much, ma'am. Thank you.
Thank you.
Mr. Himanshu, I think we can exit now.